Scoliosis, a curvature to the spine or a crooked spine. It's one of the most difficult things for us to treat as spine surgeons and for patients to live with, because we don't always want to fix the whole curve, which typically would be a fusion from T10 to the pelvis, fusing the rib cage to the hips and fusing the whole lower spine, which you lose motion from that, and it's a major surgery with a lot of potential complications. So one of the things we really specialize in, identifying what exactly is the source of the pain, and does the whole curve need to be fused, or can we do a less invasive surgery to just relieve the patient's primary problem and not fix the whole curve? So the treatment options range from non-operative treatment with core stabilization exercises in our Back Doctor app, to epidural injections, which can help temporarily, to rhizotomy and radiofrequency, which can help for several months, to minimally invasive surgeries like a microscopic laminotomy to just make a little room for the nerve, to a one-level fusion or two-level fusion, a shorter fusion, to pick off one or two bad levels, to ultimately potentially fusing the whole thoracolumbar curve. So how do we make that decision? Well, it really comes down to the history and the physical exam, nailing down exactly what is causing this person's problem. For instance, if it's generalized back pain, if it's mainly arthritic mechanical back pain, every time you move your back hurts, when you wake up in the morning your back is stiff and it takes 30 minutes to loosen up, and it's mechanical arthritic back pain, it's probably coming from the arthritis and the degeneration in the lumbar spine. And if the entire lumbar spine is degenerated and arthritic, well then fusing the entire curve may be necessary to treat that type of pain. The other side is if the pain is just in one nerve root distribution, like pain is going down an L5 nerve distribution, which goes from your buttocks down the back of your thigh, around to the side of the thigh a bit, down below the knee, it goes to the lateral outer aspect of your calf, to the top of your foot, to your big toe. If it's just an L5 nerve problem with potential weakness, such as a foot drop of that ankle where the foot drops down when you walk, weakness of pulling your big toe up, and maybe some weakness of your hip abductor, your butt muscle when you try and stand on that leg. So if it's an L5 nerve problem, sometimes the nerve is being pinched at L4, L5, right in the canal. We may be able to do a microscopic laminotomy, it takes 45 minutes as an outpatient, to make some more room for the nerve and help that L5 nerve, and that's it. No fusion, no screws and rods, just make a little room for the nerve. Now that surgery is not going to fix the whole curve, it's just going to make a little room for the nerve. But if that lasts for 3 years and allows somebody to stand and walk for longer and for a better period of time, improves their quality of life, it may be worth it. So that's part of the decision-making process we need, that really going to a physician and having a proper exam is important for scoliosis because it is so complex, and it's true for every condition, but especially scoliosis. Another alternative is sometimes we just do a one-level fusion where, say, the spine is crooked and a hole, the foramen where the nerve is coming out, is closed down, and it's just pinching that one nerve, and the pain and weakness and everything matches that one nerve distribution. Well, we may fuse that level by taking out the disc, putting in a spacer to open up the hole for the nerve, and then put in screws and rods, and it keeps the hole open. And that may treat one nerve problem with a single level fusion, just fusing one disc and not fusing the whole curve. Some examples of what we'll do is, if the L5 nerve is being pinched in this L5S1 foramen, we may do an anterior posterior fusion to open up that hole, and there's a video for that which you can watch. Sometimes we'll do a T-lift in the back where we take out the joint to open up the hole and put in screws and rods, and that's the T-lift video. If the deformity is at L2-3, L3-4, or L4-5, pinching these nerves that come out the foramen, which would be the L2, the L3, and the L4 nerve, that pain usually goes into the front of the thigh. L4 goes across the front of the thigh, across the knee to the inside medial aspect of the lower leg. That's how we know it's the L4 nerve. The L3 nerve doesn't go across the knee, it just stays in the front of the thigh. All three of those nerves can cause weakness of your quadriceps, your thigh muscle. As you go downstairs, your leg may give way because your thigh is weak. So if it's just one of those nerves being pinched due to this foraminal stenosis and deformity and closing of the hole for the nerve, we may do a lateral fusion where we go in from the side, jack the disc open, put a spacer in, and it opens up the hole for the nerve. Sometimes we add screws, sometimes we don't. Typically we do add screws, sometimes just one side, usually both sides. So there's a lot of different options for scoliosis. The real key is identifying what's the source of the pain. Is it generalized back pain, which may need a fusion of the whole curve? Or is it one nerve being irritated, which may be amenable to a microscopic decompression, laminotomy? Or foraminal stenosis, where maybe a fusion of just one level may help that problem. And again, if the surgery helps for 3 to 5 years and improves somebody's quality of life, it may be worth the risk of the surgery to do that. So you have a couple options at this point. Number one is if you want to reach out to us and contact us directly, please email us at info@watkinsspine.com and we can help sort out what's going on and how to help you. The other option is to watch the video that you think best applies to what potential surgery may help you. Thank you.